Hi, I'm Dan Konjorski, and this is the Journey podcast, uh, which is part of the Pathfinder Counseling Group here in Clarksville, Tennessee. And my co host today is Carrie Waye. She's a new therapist with her. She's a master's level therapist that specializes in play therapy with children. So tell us a little bit more about yourself, and then, go into what age group do you work with and why that age group?
I'm Carrie, and I attended Austin Peay State University.
Hmm.
I did their grad program for clinical counseling.
Okay.
I did a couple of internships, but I first started working with children at my internship at the Learning Center. Through CMCSS.
Hmm.
And there I was interning under the supervision of my professor, Dr. Kim Coggins, who is a play therapist. And there we practiced strictly child-centered play therapy, also known as CCPT. At the Learning Center, I worked with children as young as 2.5 to 5/6, 5-year-olds about to turn 6. And then while I was doing that, I applied to Centerstone for school-based therapy, and I got a position there also because my internship at the Learning Center, it wasn't going to be enough hours,
Right.
right? So we have to get a certain amount of hours to graduate. And so, luckily, I got the job through Centerstone, and I was a school-based counselor at elementary school. And that's when I started working with older children. So I worked with children there as young as 5, and then as old as like 12, pretty much 12, 11 going on 12. So K through 5th grade.
Right. But coming to work for us, you want to work with the age group from 2 to 12. Is that correct?
2 to 12, yes. Because technically CCPT, children like will age out of it
Hmm.
by 12, even
Okay.
11. Like what I found at the school is it really just depends on the child,
Hmm.
but child-centered play therapy it was founded on it was inspired by the tenets of Carl Rogers and
Right.
person-centered
Person
therapy.
centered. Right.
Yeah, and so when I work with the older kids, nothing really changes, because I'm still reflecting feelings. I'm still, holding space for them with unconditional positive regard.
Right.
I am congruent in my personality every time. So it's this presence of consistency.
Right.
And what's also similar is that the child gets to direct the session. The child gets to choose what they want to do in the session.
So, can you talk more about that? Because I know if you're a parent listening to you right now, you're like, what do you mean my child is going to direct this session? Tell us a little bit more about
Sure.
how that is played out. I'm using a pun there.
Yes.
Child centered play therapy. Tell me a little bit more how this is played out in therapy.
Yes. So, I guess I'll start with that child-centered play therapy
Mhm.
is one of the several play therapy interventions that are research evidenced under the umbrella of play therapy.
Yes.
And what makes child-centered play therapy unique is that the client has autonomy to guide the session, to lead the session.
Mhm.
So it's non-directive by nature. And because of that, actually, the child will gravitate towards activities
Mm.
that they need, right, to work through what they want to work through.
Some of those activities might be artwork.
Artwork, aggressive release play, nurturing play, fantasy play, reality play.
Okay.
And so, well, speaking of that, all the toys in the room, we say they're selected, not collected. So, often, we're perceived from the outside as you're just in a room playing with toys with my child. How is that therapy? Well, everything's very intentional in the room. And for me, I also have sand. So there's sand tray also involved in
Mhm.
my room.
Mhm. Do you know,
Yeah.
just take a break here for a minute. Do you know soldiers like to play with sand too? I'm not kidding. You take a staff of soldiers, combat leaders, and they'll take a sand tray and they'll build the battle in the sand as a way of planning for the battle.
Nice.
And
Nice. Yeah, yeah. Listen,
I thought
sand tray therapy is appropriate for any age.
right.
Any age.
Now, I
Yeah.
wouldn't call that sand tray
Yeah.
therapy. I
That
would
that
call it
is just like
a battle plan.
strategizing.
Strategizing, right.
Interesting.
So going
Yeah.
back to the children's play, you have sand trays and then
Sand, right? In like a traditional play therapy room, going off of Gary Landreth, who is kind of like the father of child-centered play therapy, if you will. He has a sandbox on the ground.
Okay.
And but yeah, so sand tray is I'm trained in sand tray therapy, so I have it in the room. But going back to the intentional selection of the toys, it's based on research, what
It's evidence-based.
it's evidence-based. Yeah. What are we seeing in the playroom? What do the children need that we've been seeing in the
Right.
research, right?
Right.
To work through what they've got to work through. Often it
Right.
is attachment-based trauma is
Right.
what I see.
So if someone maybe a child 2, 3 years old that they may, doing well throughout the session, and then he or she may just make a mess of everything, may represent anger. And then that may be a trigger for you to move into that area and ask the child, what would you ask them?
Well, so what's also unique to CCPT is that we don't ask direct questions.
Oh, okay. Tell me.
So I'll just kind of give you an idea of what happens. So we're using skills specific to the model. So that is some of them are kind of similar or the same as person-centered therapy. So unconditional positive regard, reflecting feelings,
Right.
reflecting content, reflecting meaning, limit setting. This is a big one. So when we bring the child into the room, we say, this is our special playroom. In here, you can play with all these toys in lots of the ways that you want, or in many of the ways that you want, right? Because there are going to be instances where a child will do something that is not appropriate in the room. And then when that happens, that is when we'll set the limit. So that reassures parents that we're not just letting your kid go crazy in here. You know what I mean? Everything's intentional, right? And what limit setting does, it helps the child develop self-control. It helps them redirect maladaptive behaviors towards more adaptive, appropriate behaviors.
Right. So limit setting, sort of like boundary setting.
Yes.
Setting boundaries.
Yes. And I'll give you an example. A common one is if you have dart guns in the room, which play therapy spaces have, obviously not at the school. I didn't have dart guns, but at Learning Center I did. So say that the child wants to shoot you, right? So they're they're aiming at you. First, what we do is we try to acknowledge the feeling first. And so I would say, you really want to shoot me right now, right? And then we set the limit, but people aren't for shooting. And then we give them redirection. We want to offer them at least two maximum alternatives, right? 2 is the ideal, right? So I would say you could shoot at the wall or the door. You could shoot at the wall or the bag of air. You know what I mean?
Right.
And so when we do that, we're still fulfilling that child's need, right? Because if we just told them, you want to shoot me, but I'm not for shooting, they still have this desire and need to shoot something. You know what I mean? So that's kind of what that looks like. Yeah.
Okay. So what about if the child is doing something that is expressing anger? How would you address that?
I would just let them do it. You let them express it. And if there's anything that requires a limit set, then that's when you set the limit. So we're not going into the room like, these are all the rules. You know what I mean?
But how do you explore
How do I explore?
their feeling behind that? Or do you explore the feeling?
I will conceptualize to myself. You know what I mean? Like I won't like have that conversation with a child, if it makes sense. You know what I mean? Like if a child is going at it with the bag of air, I'm going to let them. You know what I mean? And I'll reflect. You know, and it depends on what's happening. Do I need to reflect the meaning, or do I need to reflect the feeling, or do I need to reflect both? Often what it looks like for me is like, you're really getting at that. You know,
Okay.
Another thing is we don't label things. We wait for the child to label, right? Because if we label things, that will limit their imagination, if that makes sense. So,
Right.
you know, for instance, what we would call a bed they could use as a boat. You know what I mean? So we just go off of them. You know what I mean? Yeah. So we will say often like this, that,
Okay.
this, that. And then when they label it, we will, right? Because like I've got a lot of miniatures that are animals and insects, right? But I won't label them till they do, because often they see something else. You know, maybe a wolf looks like a fox to them.
I see. You know, all this reminds me of the way my daughter is raising her two children. And so that's very unique, and I like that. So almost the same principles involved.
Yeah. Which going off of that, all the skills that we use in child-centered play therapy are transferable to parents and caregivers.
Right.
Yeah.
Yeah. So this is evidence-based. This is proven to be helpful to children.
Yes.
Right. And you've had a success.
I've had a couple. Actually, I've had a few. Yeah.
More than
I've had
one
a few
is,
successes.
Tell us about one success without giving away any violating any.
Of course. Well, first I'll start with like what success looks like. To me, what it means to me is the parent will have goals for the child, right? Often it looks like emotion regulation, expressing feelings, communicating better, socially engaging. Success for me looks like we've achieved these goals.
Right.
You know, the child is more adaptive to their environment. We're not trying to change the child by any means. You know what I mean? Like, say I have an autistic child. We're not doing negative positive reinforcement. You know what I mean? Like, every child is treated the same in child-centered play therapy, no matter what they're working with.
Okay.
So oftentimes success will be the child is able to redirect themselves on their own, develop self-control, is able to express their feelings and communicate their needs.
And you've seen this. You've taken a child who wasn't able to do those things to the point of where they're able to do these things.
And the only thing I'm doing is providing that,
safe place.
Yes,
Safe place.
Safe place. I'm a safe person. They call it a safe boss. I'm going to keep you safe. And just like sidebar, limit setting keeps the child safe. It's a boundary. You know what I mean? Because children need limits to feel safe. So yes, so the child would be emotionally regulated. So this often, it comes from the parents, right? So like I see the shifts and changes happening in the room, right? And what that looks like in the room is a child used to, let's say, put sand in paint or whatever, or try to put paint in the sand tray. So the sand tray sounds very expensive and we don't want that, right? So if a child wants to put paint in the sand, that's going to require more like immediate limit setting. The sand tray is not for pouring liquid in. You can pour the liquid in this and that instead, or you could use a paint this and that instead. So I'm seeing that in the room, right? Like gradually the child will redirect themselves,
Right.
like they remember the limit and they will stop doing that eventually. And so how do these behaviors and shifts that I'm changing translate to the outside world? That's important for the therapist to know, right?
Right.
So what does that look like in school? What is that looking like at home? So what I hear from parents is it's all different, right?
Mhm.
But like, I'll just start with like a child, right? Two parents had sort of different goals for the child. One parent wanted their child to be more socially engaged, to be less fearful,
Right.
less anxious of engaging, right?
Right.
Other parent wanted for the child to communicate his feelings to her, because when he would get really upset, he would either isolate, go into himself, or he would get angry. He would throw things, hit, you know. And so the child, he's autistic, and most of our sessions were nonverbal, but it doesn't matter if it's nonverbal, right? Because we're still engaging. We can do other things, eye contact, pointing, nodding, right? Shaking the head, right? And that social relationship's building, and the therapeutic relationship in all models, right? That is like really the element of change.
That's right.
Right? And so that's research evidence also. And so, yes. So what I was seeing in the room with that child was increased confidence.
There you go.
He was leading the play more, directing more. He was just growing in that confidence, right? Finding his voice, which is, he was mostly nonverbal, but towards the end, he was speaking a little more. You know what I mean? But it was mainly what stood out was the confidence building, the relationship, the, socially engaging, serve and return. That's also, building social engagement. So the parent that wanted him to socialize, well, okay, this is cool. This is a cool sidebar, okay? Because obviously shared custody, I got both consent, right, from both parents. But mainly it was one parent who was dropping the kid off, was the main point of contact. About a couple months later, I heard from the other parent for the first time. And they brought their child in, and on the caregiver report that I give the caregivers every week, there's a part on the bottom where it gives them options if you want to speak to me, and is it urgent or can it, when?
Can it wait?
Yeah. And so this parent checked, I need to speak to you immediately, so we set up pretty much for the next day. And the first thing parent says to me on the phone is, I want to know what you're doing because it's working.
There you go.
And so what that looked like outside was the child was fearless. He was himself, joining activities. There's a group of kids, I'm going to engage. You know what I mean? Instead of being on the sidelines. Yeah. So that parent saw fearlessness, social skills. And the other parent said, instead of acting out or going into himself, when he has big feelings, he will come up to me and he will give me a hug.
Right. Oh.
And he'll say, I love you. That was another thing. He was saying, I love you to both parents.
Oh, yeah.
And
he wasn't before. No.
I don't think at that much, you know what I mean? And so, or I don't know, I didn't ask that question actually.
But they were surprised at it, and they shared that. Yeah, there you go.
They were very moved. I was very moved, and all that to say is I'm not taking credit for the child's change. That is in the child. You know what I mean?
But you are facilitating
exactly.
You're facilitating that change.
Absolutely. Yeah. Facilitating it through the relationship and supported by the skills and techniques of CCPT.
Yeah. I'm here with Carrie Waye, and she is part of the Pathfinder Counseling Group here at 101 Hatcher Lane. Her play space for your child is in Suite B at 101 Hatcher Lane. And if you would like to find a play therapist for your child, I would highly recommend Carrie Waye. And you can call us at 931-444-5630 for more information. Carrie, I look so forward to having you on the journey again,
Thank
where
you.
we can talk some more about
Thank you.
CCPT, which is child-centered play therapy, an
Yes.
evidence-based therapeutic treatment for your child.
Mm-hmm.
Okay.
Mm-hmm.
And you also use sand tray therapy.
Yes.
Yes.
But I also, before we end, I want to say that we just need to believe children that they are capable of growth and change.
Right.
That I believe there is no such thing as a bad kid. I think that children who have big behaviors, who lash out, who are emotionally dysregulated, they're doing so because they have big feelings that they don't know how to communicate, right?
Yeah.
They also feel misunderstood.
Mhm.
You know what I mean? These behaviors don't come out of nowhere, right?
Mhm.
And more often than not, I see in my kids attachment-based trauma. Okay.
Explain a little more about attachment.
How much time do we have?
Maybe.
It sounded like you were wrapping up right
Okay. Yeah. So why don't we do this at our next
Okay.
our next video, the journey.
Let's dive in. Yeah.
Attachment-based trauma. I think that's very important that we go over that and explain
Yes,
that some more.
absolutely. Yes,
But Carrie,
because
yeah.
people don't really, when people think of trauma, they don't really think of attachment-based trauma. So we could talk about that.
Yeah,
next time.
we will talk about next time. Again, Carrie, I appreciate you being part of the Journey podcast, as well as being part of the Pathfinder Counseling Group.
I'm happy to be here. I'm so happy.
And I am so grateful that you were referred to us by someone else in our group.
Yes.
Another therapist, Miss Tara.
So grateful.
Yeah, and I'm glad you found us. And we all know Dr. Batts and Dr. I know Dr. Coggins as well. And so it's just great to have you with us. And we look forward to
Thank you so much.
Reaching the Clarksville community and their children.
Thank you. I'm really grateful for the opportunity to be able to be a part of another practice offering child-centered play therapy.
Yes.
I think it's very much needed in our community.
Okay.
So thank you, Dan.
Yep. So again, my name is Dan Konjorski, host of the Journey podcast. Please visit us again in the future, and maybe next week we'll talk about attachment-based therapy.
Sounds good. Bye.
Bye-bye.